Good afternoon, everyone. Thanks for joining today for our final installment of our Healthier Washington VBP webinar series. This webinar will be focused on value-based purchasing and Medicaid transformation. My name is Kennedy Swallow. I will be your moderator today. I'm the Health Transformation Communications Manager for HCA, and it's a pleasure to be here with you today. Before we get started, I just want to go over a couple of housekeeping items. This slide is going to show you how to connect to audio and also how to ask questions. I just want to let you know that your phone lines are going to be on mute for the duration of this webinar, but please feel free to ask questions at any time using that questions field, and we've set aside some time later in the webinar for some Q&A. Hopefully we'll get to your question, and if we don't, we will be sure to follow up with you and get your question answered if we're not able in the time frame that we have today. This webinar is being recorded, and that recording plus a copy of the slides will be available on the Healthier Washington website in the next few days, so be on the lookout for that. With that, I want to introduce who will be speaking today. Today, we're going to hear from J.D. Fisher, Medical Program Specialist. We'll also hear from Mark Province, Director of the Office of Medicaid Transformation, and Chase Napier, Healthier Washington Community Transformation Manager. And of course, I'm Kennedy Swallow, the moderator. With that, I'm going to kick it over to J.D. to get us started.
Thank you, Kennedy. So before we jump into the transformation aspect of this, I wanted to give a brief overview of who the Healthcare Authority is. We are the state agency that is responsible for purchasing healthcare for over 2.2 million individuals in Washington through our Medicaid program, also called Apple Health, and our Public Employee Benefits program. And beginning in 2020, we will also be responsible for purchasing care for all statewide school employees. We spend over $10 billion annually on these healthcare programs, and critically, despite the differences between Apple Health and our employee benefits programs, there's a significant overlap in terms of provider networks, so that regardless of the program that patients are in, they're getting care at roughly the same places, which means that the impact of any clinical policies and payment programs instituted in one program will invariably impact the others. We've set ambitious purchasing goals for the state as the agency and the state in general. By 2021, we aim to drive 90% of state-financed healthcare and 50% of the commercial market into value-based payments. Some of our purchasing decisions are driven by executive order, the legislature, or through federal grants and initiatives. We have a purchasing mandate given to us by the legislature in 2014, directing the Healthcare Authority to implement value-based purchasing strategies. We were awarded a SIM Round 2 grant from the Centers for Medicare and Medicaid Innovation that runs through January of next year. And we now are in the second year of a district Medicaid transformation project that will run through 2021. As the Healthcare Authority and our partners continue to adopt new and sustainable advancements in healthcare, we also want to ensure that there is reliability in today's unpredictable and complex healthcare environment. We aim to do this by designing a system that really drives at better outcomes. This requires a shift in focus, and we're shifting towards strategies that address a system that is full of disparate incentives and disparate outcomes. Some of these focus areas include value-based purchasing, where we are leveraging state-financed healthcare purchasing programs, as mentioned before. We're looking at whole person care through financial and clinical integration. We're looking to use data in meaningful ways in order to support providers transform care at the point of service. And we're looking for opportunities to leverage federal dollars to innovate and transform the healthcare system throughout the state of Washington. We also understand that culture change is an essential part of the journey towards population health, and that we can address these through collaborative partnerships. By taking a regional approach to transformation through accountable communities of health, addressing social determinants as a key driver of health, supporting family caregivers and ensuring that people can avoid high cost and low value care settings, and addressing workforce challenges, we believe that we will succeed in driving towards improved population health management and ultimately better health status for Washington. To outline and promote how we plan to arrive at our goals, we've put together a value-based purchasing roadmap that we update annually that highlights how we are using incentives to drive change in the system. We've set up a handful of guiding principles that really outline every aspect of this work. We aim to reward the delivery of patient-centered, high-value care and increased quality improvement. We want to reward our Medicaid and employee benefits health plans and health systems for improved performance. We're tracking closely what's happening at the federal level and want to align our reform approaches with those happening through the federal government so that our providers are receiving consistent signals. And we want to drive standardization that is based on evidence. We hope that this will increase long-term financial stability and sustainability for our state healthcare programs and the providers that we partner with. And we're continually striving for the triple aim, and better yet, the quadruple aim of better health, better spending, and health and better care, and also better provider satisfaction. This roadmap is updated annually, as I mentioned, and describes how we're aligning strategies and resources across our various healthcare purchasing programs. And again, we set this goal in 2015, and in 2016, we wanted to be at 20% of value-based purchasing and drive to 90% by 2021. And through our internal evaluation, we found that we were actually at about 30% in calendar year 2016. So we are doing well so far. Just to give you a few examples of what we've done so far in terms of value-based purchasing across our programs. Between our public employee benefits program and Apple Health, we've instituted a number of value-based purchasing efforts. We launched an accountable care program, which is an ACO type model with upside and downside risks in our public employee benefits program. This program really incentivizes clinical and quality improvement and holds providers and networks accountable to those goals. We launched the Total Joint Replacement Bundle through a Center of Excellence with Virginia Mason last year, and we currently have an RFP out for a spinal fusion bundle. In a recent contract that we signed with Regents to be our third-party administrator for our self-insured program for public employee benefits, we're requiring them to offer a similar accountable care product to their other lines of business. So we're using our levers to try to influence the marketplace more broadly. In Apple Health specifically, we added a 1% premium withhold to our MCO contracts and tie that withhold to quality and value-based purchasing targets. We're integrating behavioral, we're financially integrating behavioral and physical health through Apple Health, starting in Southwest Washington, and it will be statewide by 2020. We're exploring a multi-payer payment model that would be value-based and really impact rural health care settings and try to improve the performance and sustainability of rural health systems. And we've launched the Medicaid Transformation Project through tying regional value-based purchasing goals to incentives through the district program. So with all this talk about purchasing, we don't want to leave unsaid the critical importance of practice transformation. And while VBP is paying providers to care for patients in a different way, we understand that there needs to be the much significant pre-work and reorganization of clinical practices and rethinking team-based care in order for providers to succeed in a value-based payment environment. We can't solely rely on incentives to change clinical behaviors, and so we want to ensure that we are targeting practice transformation from multiple avenues. Practice transformation happens in tandem with VBP incentives, and we're encouraging providers to participate in new payment models as well as practice transformation efforts. We believe that organizations that embrace patient-centered care will in turn develop high-performing patient-centered care teams that will really drive safe, effective, efficient, personalized, timely, and equitable outcomes for their patients. To support providers in achieving this transformation, we're using multiple levers through value-based payment, through the Practice Transformation Support Hub, through our accountable communities of health, and through our managed care organizations to deploy practice transformation technical assistance and ensure that providers are well positioned to succeed in this new environment. I'm shining the light a little closer on Medicaid, just to summarize where we've been today, or by today. Through our State Innovation Model 2 test grant through CMMI, we've established the accountable communities of health that are really facilitating our regional approach and community engagement in this effort. We're moving towards integrated managed care and really excited to have that statewide by next year. And we're building out the practice, we built out the Practice Transformation Support Hub and have had some really successful projects through them and supporting providers. Again, we launched the 1% withhold in our MCO contracts, and we've convened a think tank that we call the Medicaid Value-Based Payment Action Team that supports providers, managed care organizations, and accountable communities of health in attaining VBP targets. We have a significant opportunity through all this work and the work that's yet to come to build on this foundation through the Medicaid Transformation Project. And now I'm going to turn it over to Mark Province, who will go into a little bit more detail about the transformation and its relationship to value-based payment.
Thanks, JD. Good afternoon. This is Mark Province, Director at the Office of Medicaid Transformation at the Healthcare Authority. So kind of picking up from the themes that JD established and taking a closer focus on our Medicaid Transformation Project, this slide really captures, I think, the fact that value-based payment is a critical component to the success of the Transformation Project. And as a reminder, the Transformation Project started last year in 2017, runs through 2021. It's a contract with the federal government, one significant part of which is a promise by the state of Washington to demonstrate to ourselves and to the feds that we can achieve the kinds of transformations that we've set out in such a way as to not only achieve value-based payment structurally, but reap the benefits of value-based payment by reinvesting in the Medicaid program. So we have essentially still a fixed pie to deal with, if you will, in terms of resources available, but we think we can deploy those resources more effectively through some of the transformations that we achieve. And I think really thinking about value-based payment, you can think about the goals of the Transformation Project in three ways. One is we've set out to drive value by the way in which we've designed the project, and more specifically, designed the Medicaid Transformation projects that the ACHs will be undertaking. We've set out to measure value in terms of some of the measures that we'll be applying that derive, many of which derive from our statewide common reward value, by allowing the ACHs and in fact requiring the ACHs to use incentive dollars to really reinvest into the transformation of the delivery system for Medicaid. This hopefully will not be new to most of you, but this really reiterates that we're out to achieve and support the triple aim. This is actually, as JD mentioned, it's actually the quadruple aim. But these are really the goals that we've set out as part of the Medicaid Transformation Project, and again, that are reinforced by and in turn reinforce the goals of value-based payment. Reducing avoidable use of intensive services and settings, which of course is not only better for patients in terms of outcomes, but better in terms of helping to contain costs. Improving population health, which really takes a focus on whole person care. Accelerating the transition to value-based payment. And it's both, again, it's not just the payment piece, it's both the value piece and the payment piece. So you can think of it in a way as the numerator and the denominator. We're seeking to improve the value of what's delivered and measure that value, and we're seeking to reward and reinforce that value through means of payment. And finally, ensuring that Medicaid per capita cost growth is below national trends. Again, emphasizing that the fact that we're not counting on new money to the Medicaid program, but rather reinvesting the money that we have and spending it in more reasonable and rational ways. Oops. again, some of you have seen this before, but this is just a reminder that there are three components of our delivery system reform incentive program under the Medicaid transformations. It's also sometimes referred to as Initiative 1. But these really represent the key components of the projects undertaken by the ACHs. And I want to call your attention especially to the building blocks, the foundation stones, if you will, at the bottom of this slide, one of which, of course, is financial sustainability through value-based payment. So we have very specifically called out VBP as an essential ingredient in supporting the success of the projects undertaken by the ACHs that are represented in those upper two tiers, care delivery redesign, and prevention and health promotion. This is a reminder of the array of projects available to the ACHs and those that have been committed to by the ACHs in their recently approved project plans. So you can see that we've, the green highlighted items are the two required projects of every ACH, and that's bidirectional integration of care and addressing opioid use. You can also see from this slide that all 9 ACHs chose to undertake projects in chronic disease prevention and control. And then you can see the distribution among the remainder of the projects across the ACHs. I think it's important in thinking about value-based payment and value-based purchasing to note that the ACHs, as they undertake these projects, really are focusing both on the processes and the outcomes parts of value. In other words, how can they contribute to improvements in delivery system design, which attends to the process part of value and achieving value, and also how can they attend to achievement of the outcomes that will be required to measure over the course of the demonstration in terms of improved health and improved health status of the populations they serve. Remembering, of course, that this doesn't focus just on the clinical delivery system, but focuses on the other contributors to health that go beyond the delivery system components themselves. I also want to remind folks that these projects are not undertaken in silos, that in fact the ACHs very much look across these projects in thinking of the projects as part of an entire portfolio of services undertaken. And it's very important to remember from those foundation stones that you saw on the previous slide that value-based payment, value-based purchasing underpins all of these projects across the project categories that you see represented here. Delivery system reform is really a process and a progression across the 5 years of the demonstration. Now it's hard to believe only 4 remaining years of the demonstration, but really starting, and what this slide indicates is the investments of incentives that begin with the design of these projects and how ACHs are partnering with their providers to apply the incentives. It's important to think about those incentives applied across the lifespan of the Medicaid transformation project, but really merging from the application of those incentives into redesigning how we deliver care and how we think about care as delivered to the Medicaid population, and transitioning to really that goal at the kind of at the bottom right of the slide of a transformed system of health and wellness. I'd also remind folks that when we talk about providers with respect to Medicaid transformation, again, it's not just clinical providers that you might think of traditionally in terms of physicians, hospitals, and other clinical delivery settings. But the ACHs are thinking about providers much more broadly in incorporating community-based providers and other parts of what we would consider as an expanded delivery system, if you will. ACHs represent pretty broad tables around which a number of those folks assemble, not just the folks providing clinical care. And just to wrap up my portion, I do want to note that we're thinking about really 4 key ingredients when it comes to the role of ACHs and how that role is thought of with respect to value-based payment and value-based purchasing. And there are, from a provider perspective, 4 key ingredients that are wrapped up under the goals of value-based purchasing. One is an attributed and identifiable population. It's important if you're trying to transform the delivery system and trying to measure the value that you're deriving from the investments that you're making, to know who you're talking about in terms of the population affected. So as we progress under the project, we'll be looking very specifically at those 9 regions served by the 9 ACHs and their MCO partners, their health plan partners, in thinking about how we can best measure the effects on the population of the interventions that are made. Second key ingredient is an accepted and measurable definition of value. Of course, this is a big challenge for all of us. How do you measure the value that's delivered, the value that's derived, and the value that's experienced by the patient? We have, as I mentioned earlier, a number of measures that are derived from our common measure set that we think are a good place to start. But we're also relying on our ACHs and their provider partners to help us define what is value when you're thinking about improvements in the health care and health status of the population served. The third key ingredient is a means of collecting reporting information and data on those measures that tie really to that item number 2. In other words, once you've determined what kinds of measures you want to apply to value, you have to have good sources of data and information to know how you're doing relative to those measures for that population being served. And finally, a means of influencing behavior, and I might substitute almost outcomes for behavior. In other words, once you've identified your measures, once you've determined you have data to measure them, by what means do you influence the kinds of delivery system reforms that we're talking about? And it's important to remember here that the incentives, while the financial incentives are important, and we don't want to lose sight of them, those aren't the only incentives that folks respond to. When you can provide timely feedback, for example, to a provider on how they're doing relative to the measures that you've set, that can often be just as effective an influencer in terms of behavior change and orientation to outcomes as financial incentives. We tend to think of the financial incentives in that sense really as being a way of reinforcing the kind of system change that you can see when you apply those measures and report them back to the provider community. So with that, I am going to hand the microphone and slides over to Chase.
Thanks, Mark. Great. So I get to talk a bit about roles within the context of value-based purchasing and payment. And to start with, we're going to look at the healthcare authority, managed care organizations, and providers. And some of this is to set the backdrop for where do accountable communities of health fit in. And we mentioned DSRIP, which is really the Medicaid transformation project and the delivery system reform component of that. And so this backdrop will help to get more clarity on the opportunity that exists within that program. So in really simple terms, the healthcare authority ultimately is advancing VBP through the incentives and contracts and mechanisms that JD covered at the start. That includes innovations like Medicaid transformation project, the state innovation model grant, etc. And then really importantly, it includes our contracts and the Medicaid managed care program itself. Managed care organizations then in turn are contracting with providers, setting up those payment methodologies that support quality improvement and health outcomes according to the goals and targets that are shared between the healthcare authority, managed care organizations, and our partners statewide. Providers are, of course, also part of that contract negotiation process and ultimately are performing according to those targets for quality and health outcomes and using the value-based arrangements to build sustainability into their delivery system and care models so that the transformation is long-term and sustainable to continue performing and providing the highest quality care and focusing on what provides, what contributes to those health outcomes. The ACH support role, so kind of separate from what we just covered, getting into where does the ACH accountable community health fit within this. There are specific opportunities under DSRIP, which stands for Delivery System Reform Incentive payment. So that's a component of the Medicaid transformation project that Mark talked about. And really, those resources specifically support sustainable transformation. That includes how do we help providers to take on VBP arrangements to be able to build the necessary capacity and infrastructure. We'll actually go through a specific example of how could that work using the resources under DSRIP. But ACH is also, separate from the resources under DSRIP, are really in a good position of facilitating conversations that do focus on team-based care, whole population, and whole person health, really thinking of all of the partners within the community that contribute to health and are part of how we define value. And so ACH is really a unique opportunity for that. They don't interfere with the contractual side between managed care organizations and providers. But again, as those stipulations and targets and performance expectations are mapped out, ACHs do represent the collective community partnership that can address those health needs, because some of those health outcomes we know are outside of the delivery system, the healthcare setting itself, and require more collaboration with community partners and community-based organizations. The other thing I would note is that as much as we talk about the Medicaid Transformation Project and the role of the ACHs, that is only a fraction of the resources that are going into the Medicaid Managed Care Program. So as we talk about alignment and sustainability, it's really important to understand that there is significant opportunity provided through the value-based strategy that JD described through the Medicaid Managed Care Program, and Medicaid Transformation is an opportunity to identify that path forward and reinforce that, to provide those reinforcements for providers and those supports, including how you can connect community-based organizations and other providers to our current healthcare providers. So taking a look at a specific example, just really quickly, of a VBP funds flow. So on the MCO side, under the Healthcare Authority, there's a contract and there's a withhold that relates to the types of VBP arrangements and the number of VBP arrangements, also the quality of care that's provided within those arrangements, and the types of incentive payments that are going to providers. So ultimately, all of those incentives and signals should result in higher value care, and then providers are receiving reimbursement and rewards for providing that higher quality care or achieving certain health outcome targets. And that is part of that sustainability loop. But then those providers can keep that funding into that new delivery system, that new model of care, to continue providing value and contributing to health outcomes. The ACH, in a very separate role outside of the contracting and value-based payment arrangement perspective, can reinforce, can use the opportunity of Medicaid transformation to provide practice transformation support if we're talking about integrated care, team-based care. If we're talking about care coordination, how can ACHs make sure that those community partners, community-based organizations, and all of those that contribute to health factors, even if they're not necessarily in the primary care setting or the behavioral health setting, how can they be connected in as part of this model and this program? And all of that does, similarly to the MCO arrangement, it does contribute to higher value care and should reinforce those financial incentives on the provider side to sustain those efforts. So again, this is just a picture of more of the funds flow role that the ACH can play using the resources under Medicaid transformation. They're in the position to design these projects and these activities that Mark talked about, and can really align with the same efforts that are being provided through the managed care side and those contracts with providers. So it doesn't have to be distinct and separate. It really could be a perfect alignment and reinforcement. And then really an opportunity now and long-term that the accountable communities of health could provide is just thinking of the importance of clinical community linkages, all of those factors that contribute to health that need to be part of a more cohesive and connected system. And those are the partners that are at the accountable community of health table. And so even beyond Medicaid transformation, there's an opportunity for the ACHs to support those outcomes that are going to be built into how we define value, how we measure value, and ACHs represent those partners that are going to make that possible and make that successful. So that's kind of the quick run through of how the ACHs fit in and how the role of the accountable communities of health can be supportive but completely separate from the contractual relationship between managed care organizations and providers. And with that, I think I'm going to hand it back to Mark to talk about next steps.
Great, thanks, Chase. Just to wrap up, as a reminder, and this goes back to something that we covered earlier, health is more than healthcare. We realize that in terms of the responsibility for utilization of resources, a lot of the focus obviously focuses on or falls on the 20% represented by the healthcare delivery system. But one of the things that we're trying to achieve, and I think we've laid good groundwork for with the ACHs, is the incorporation, the recognition and incorporation of the other components that are responsible for the health status and the healthcare experience of the people we serve. One of the challenges, and this goes back to something I said earlier, is knowing how we can best measure the value that we're deriving in each of these segments. Because of healthcare, the healthcare system and the access to claims data, for example, that we have, we know a number of ways in which we can focus on outcomes and experience in the healthcare delivery system. It becomes a little bit more of a challenge if we think about the other pieces of this pie, thinking about socioeconomic factors, health behaviors, physical environment. But there again, this is where, in partnership with our ACHs, we're hopeful that we can begin to demonstrate the effect in those other segments, or on those other segments, of the kinds of delivery system reforms that we're promoting and contemplating under the Medicaid Transformation Project. This is also a reminder, again, that when we talk about providers, it's a pretty large table, and there are many in the community who affect and contribute to the health and the health status of the populations, both really in our Medicaid population, but the others that we serve here at the Healthcare Authority. Takeaways, I think there are several, and hopefully these will resonate with those of you listening in this afternoon. One is a reminder: Washington State is transforming the way it purchases healthcare. This goes all the way back to some of the opening slides that JD used, and is a reminder that the Healthcare Authority exercises a fair degree of influence on the delivery system through the $10 billion of purchasing that we engage in. We take that responsibility seriously, and that's one of the reasons why value-based purchasing and value-based payment is such a significant part of our vision and a significant part of the relationships that we're establishing with our health plans, with our ACHs, and others. Secondly, HCA is aligning its business with the national movement away from fee-for-service to payments based on value. For some of you, this may translate, hopefully, into a message that we're trying our best not to drive providers crazy with too many different types of measurements, too many different types of approaches to value-based payment. As many of you may be familiar, we have used what's called the HCP LAN framework. It's just really one way of thinking about the progression away from fee-for-service toward value-based payment, looking at ways of applying incentives, especially in terms of payer-provider relationships, moving from fee-for-service to rewards for improved outcomes, moving from that to elements of upside and downside risk sharing with providers, and all the way, in some cases, to population-based reimbursement, thinking about responsibilities exercised by providers over entire populations that they serve. All that to say that we're looking to be consistent with what other major payers are doing, such as Medicare and commercial payers. Thirdly, Medicaid transformation continues through 2021, but I would encourage you to think about it not just stopping at 2021. In fact, what we're trying to do is, again, lay the building blocks demonstrate the interventions that are successful, and then use that experience to really make these kinds of transformations and interventions sustainable beyond 2021. So while those of us who are focused on the Medicaid transformation project are very acutely aware of this 2021 end date for the project itself, we are very much committed, not only as a project team, but as an agency, to making sure that the successes we derive are sustainable beyond that year. And finally, the end result really is intended to be better care, healthier people, and lower costs for Washington residents. So with that, I think we're going to open it up to address questions that have come in.
Thank you, Mark, Chase, and JD. This was a great presentation showing the critical connection between VBP and the Medicaid Transformation Project. Like Mark said, we're going to open it up for questions, so please feel free to use the question field to ask anything. And I'll start out with a question we received, and I'll just throw it up to the three of you to decide who wants to answer. When attributing a population to a healthcare provider, what feedback is available to the provider when the patient assigned to them is not responsive to outreach?
I'll start and ask my colleagues to jump in. It's a good question, and I think illustrative of one of the challenges with respect to this question of attribution. Probably in its simplest form, one answer is, with respect to Medicaid at least, we know that Medicaid members are assigned to their respective NGOs. I realize that to the question that doesn't necessarily address all of the challenges, because then from the NGOs, Medicaid members are assigned to primary care providers, but may also receive their services from many different providers, either within or outside of the given healthcare system. So this question of attribution, in fact, it's interesting that this comes up because it just came from an earlier conversation with our data group where we were actually talking about this very subject. All that to say, it's very much on our minds in terms of how can we tie the experience and the outcomes of individuals and populations back to the performance of providers. Suffice it to say, we're trying to figure out the best way in which to do that, but it's not an exact science. One of the things that we've emphasized with our ACHs in their projects that they're undertaking is that there's a certain level of accountability between the ACH and the healthcare authority for performance in a project. And we recognize that that performance may be accomplished through relationships with a number of different providers. And sometimes those providers, in terms of their delivery systems, cross boundaries between one ACH and another. So I think we'll be continuing to try to address this question as best we can, but I'm not sure that we have a ready answer to it other than to say we're very aware that this is a challenge.
Thank you. The next question, I think maybe I'll ask JD to take a crack at it. Please define integrated managed care.
Sure, thanks, good question. So traditionally, we have financed physical and behavioral health care separately. So MCOs were given premiums to manage the physical health of a patient, and the behavioral health needs of an Apple Health client were taken care of through, I believe, behavioral health organizations in a completely separate financial model. So the money was flowing to two separate organizations responsible for two separate and disconnected aspects of a patient's care. By integrating managed care, we are combining the financing of both physical and behavioral health care such that premium payments are flowing to managed care organizations who are then responsible for both the physical and behavioral health care management of their clients. So this involves really realigning how those behavioral health organizations function and giving more responsibility to the managed care organizations to manage the financial portion of behavioral health. That's just the financing side. We realize that there are significant impacts on the clinical side in terms of caring for patients in this way, and that by simply changing, what's included in the premium payment to MCOs, it's not necessarily going to translate to the clinic level. So we're working with providers and managed care organizations to find ways to include behavioral health specialists in their practices and connect with behavioral health organizations so that those patients' physical and behavioral health care becomes coordinated and integrated beyond just the financing.
Thank you, Jason. Another question, is the enrollee Prism Score going to be available to providers in a timely manner, meaning within months? And I think I'll just add, if you want to explain what the Prism Score is.
This is Mark. So the Prism Score is a metric established by our colleagues in research data and analytics. I've got the RDA acronym correct at BSHS, and it's been used really to help identify those individuals who might be at a higher level of risk with respect to their health status or health outcomes. I don't think I know the answer to the availability of Prism Score data, but we can probably check into that and try to get an answer back out to folks.
We definitely will. Another question came in. There seems to be a lot of emphasis on use of evidence-based practices in the transformation, but a majority of EVPs have not been normed to include communities of color. How will HCA ensure that these communities and providers that serve them are not negatively affected by the system change?
This is Mark. We have on our staff a couple of individuals who are working specifically on issues of health equity and disparities, and in conjunction with actually a committee of our Health Innovation and Leadership Network, also called HILM. We recognize that one of the challenges historically with some of the measures that have been applied, both in terms of the numerator, in terms of health status and outcomes, and also the denominator with respect to how populations are defined, fall short in really measuring differences both in outcomes and experience between populations. So we have incorporated, I think, as part of the requirements in the project toolkits, in our communications with ACHs, the requirement that they attend to, the attention to, I should say, experiences across populations as they roll out and implement the projects that they're undertaking. And we'll be continuing to work with the ACHs, learning from them, but also trying to provide any guidance we can on how to better identify measures that can more effectively distinguish between elements of the population, between population groups, with specific reference to disparities and health equity. So probably more to come on that, but we are attending to that, and we do recognize it as one of our measurement challenges.
And this is Chase, and ACHs as well are working on incorporating health equity in a meaningful way into their project planning and support and resources. So it's a shared desire that the Healthcare Authority holds, but also ACHs are in those discussions. We're talking also about are there shared technical assistance opportunities? Are there ways to convene more intentionally around this topic, especially thinking of the opportunity with the Medicaid transformation and those resources. So there should be more action this year to explore that very question in more detail.
Great, thank you. Another question came in. What are the main challenges that the ACHs are encountering in advancing VBP? For example, how active are the commercial payers in supporting VBP and coordinating their efforts with the ACHs in their regions?
I can start. This is Chase. So just speaking to some of the context that we have gathered and conversations we're in, I would say commercial plans are not as engaged right now as we would like to see. I think Medicaid transformation and resources and the alignment with our value-based roadmap is an opportunity to better engage commercial plans. part of it is the developmental phase we're in. We're in an implementation year this year, so I think that there's still plenty of opportunity to pick up that engagement and work on alignment. That being said, on the managed care side, very engaged are the managed care organizations in the ACHs, and I think the challenges there are really just for the ACH to find that right opportunity to provide the reinforcement and the support while not being in the middle of those contract negotiations, and so not having all insight on what those arrangements are with providers and what those next steps are from the managed care perspective, but being able to at least leverage the partnership and the fact that everyone's at the table talking about this. But I think we need to go the next step and go one step further to really figure out what is the need that ACHs can reinforce without taking on or getting in the middle of those negotiations themselves.
This is JD. I would also add that we are cognizant of the challenge that ACHs face in engaging commercial payers, and this is another example of how we're trying to use our multiple levers as the healthcare authority, where we purchase, not just for Apple Health, but also for public employees. So through our public employee benefits program, we have embedded requirements of our accountable care program networks to engage with ACHs, and it's also a component of our new TPA contract with regions that will begin in 2020, that they support the goals of the accountable communities of health and the Medicaid transformation. Some of this is fairly undefined, so while those requirements are in contract, what that looks like and what that means on the ground may not have a fully baked definition, but we are definitely committed to making sure that we are using our levers to bring together our resources through those other programs to support ACHs.
This is a somewhat related question. How are you holding MCOs accountable to VBP with providers? Are they still using fee-for-service methodologies and not talking about strategies to integrate behavioral health providers into VBP methodologies?
Can you say the question one more time?
Sure. How are you holding MCOs accountable to VBP with providers? Are they still using fee-for-service methodologies, not talking about a strategy to integrate behavioral health providers into VBP?
Great question. So the approach that the healthcare authority has taken with our value-based purchasing in Medicaid has been to put requirements in the MCO contracts that they advance value-based purchasing with their provider partners, but we're not taking a prescriptive approach where we dictate to them what type of payment models they develop and implement. So we are using the HCP LAN APM framework, the federal VBP framework that defines what value-based payments are. There are specific categories in that framework that the healthcare authority has identified as being truly value-based. For those familiar with the framework, it would be categories 2C and above. Really what that means is those payment categories and those models tie payment to quality performance on some level, whether it's pay for performance on a subset of quality measures, whether it's shared savings, where the savings are doled out based on performance of quality measures, or if it's a full capitation arrangement where there are bonuses or penalties for performance on quality measures. So again, we're not being prescriptive, but we are tying portions of the withhold to different aspects of those payment models. At a high level, there's three components, one being quality performance. So the MCOs have to report to the healthcare authority on quality measures across their provider partners. That performance will earn them a portion of the withhold back. A second portion is their degree of value-based contracting, so how many of their contracts with providers are in those value-based arrangements. And then the third component really gets to the dollar flow and how providers are being paid. So the third component is the proportion of dollars paid to providers in the form of incentives. So for instance, is a contract with a provider is a shared savings arrangement? Well, what portion of that savings are eligible for providers to earn back. That portion would go towards that incentive component of the withhold. So the idea and the theory behind that is by putting those requirements in place, the NGOs will be able to engage providers where they are and implement appropriate payment models for providers and relative to their capacities. And really, our aim is to move away from fee-for-service.
Great. And how has HCA worked with other government entities to ensure we have sufficient workforce to be successful? How are you addressing workforce shortages in primary care and behavioral health?
Shane, I can start just with one perspective. So Mark talked about the kind of framework of Medicaid transformation, and so thinking of Medicaid transformation as an opportunity specifically, there is the foundation really, and one component of that foundation is workforce and practice transformation. And we do know that there are the short-term needs and long-term needs. I think that's where the challenge lies. But we are engaging. There's a workforce lead that is reaching out to other agencies, including the Workforce Training and Education Coordinating Board, and then also identifying those local workforce champions and even the workforce leads within the ACHs to try to bring everyone together to talk more about the long-term needs when it comes to big issues like primary care and behavioral health and different workforce shortages. Those aren't going to be easy to tackle in the next 6 months to a year. And we also have some other practical practice transformation efforts that are going to be underway. So I would say it's both. How do we maintain that long-term vision and bring those partners together, which is happening, but also we have opportunities in these projects to address specific practice transformation and training needs that exist with the current workforce.
Great, thank you, Chase. Another question came in about another aspect of Medicaid transformation, foundational community support. This question asks, the AmeriGroup contracts for foundational community support, which is supported employment and supported housing, are fee-for-service based and not VBP. They suggest the use of EBPs, but do not fund it. Is there a plan to change this?
This is Mark. So we do have a contract with AmeriGroup as our third-party administrator for the Foundational Community Supports Program. And the relationships in terms of payment relationships with providers probably do need to derive first and foremost from more of a fee-for-service kind of relationship, in part because this is a developmental program. If you think about the definition of the services and the means of collecting data on services provided. That said, I think there certainly is room for considering and wanting to consider evidence-based practice as we progress in terms of the development of the Foundational Community Supports Program. So that's the question actually serves as a good suggestion and a reminder for us to make sure that we don't stop short in the compensation arrangements that are established, but think about are there ways in which, again, thinking about that value equation of outcomes achieved relative to the investment made. But I would say that probably it's reasonable for us to start from a perspective of making sure that first and foremost we have services well defined, we have the providers engaged, we have the mechanism for making sure that we can compensate those providers for those services, and then look to make sure that we, in our purchasing of those services, can think about the same kind of value-based continuum that we've established in our other relationships.
I think we have time for one more question. I just want to remind the audience that if we didn't get to your question, we will be sure to follow up with you. The last question is, what does VBP mean for patients? Will they experience anything different?
That's also a very good question. And the goal is an absolute yes with exclamation points. The ideal is that patients in this value-based environment would experience a more connected and coordinated care from one setting to the next, that they would receive fewer, if at all, any low-value services or duplicative services. By holding providers accountable to outcomes, you know, in the long term, patients should be healthier and achieve better health status. Their chronic conditions should be better managed. They should feel more supported by a team of physicians and their supports. Through the transformation, we expect that patients will experience better coordination in their communities with social services and community-based services, and that those services would be better linked to the clinical settings so that they aren't, patients aren't experiencing, you know, completely disparate care transitions from a community-based setting to a clinical setting. The patient aspect, you know, the health outcome aspect might be a little more long-term, but we also expect that some patient engagement aspects of these payment models would improve the experience of patients within the clinic walls. We're closely tracking and looking at patient-reported outcomes, for instance. And from the benefits side, you know, I can speak to this from the public employees side. You know, as we construct benefit options through our employee benefit programs, we really are taking care to structure those benefits such that they make better sense for the members, that it's more understandable what their benefits are, where to go for care, who to call, that providers are open at more convenient hours, and that there are better options for things like telemedicine.
Thank you, JB, and thank you again to Mark and Chase. It's been a great hour, and I also want to be sure to thank everyone on the line for joining us today. Be sure to look out for the webinar recording and slides on our website. And with that, everyone have a great afternoon. Thank you.